And then I'll just introduce you. One thing before I start is, what's your preference in terms of questions? Do you want questions at the end?
Sure. I mean, if someone has a burning question during the talk, I'm totally comfortable with someone asking while I'm speaking, but I'm also happy to take questions at the end, whatever works for your group.
Okay, we'll follow up the chat. I guess you will not be able, but we'll keep an eye, and then if there's anything, we'll let you know. Okay.
Okay.
Okay. So, hello everybody. It's good to see you all. Although through Zoom this afternoon, we have a great attendance. It's my great pleasure to introduce you, Dr. PJ Devereaux. He's as you've seen from his bio, he's a very accomplished clinician scientist. He's a cardiologist, an epidemiologist, professor, and university scholar at McMaster University, director of the Division of Perioperative Care at McMaster University, senior scientist and scientific leader of the Anesthesiology, Perioperative Medicine, and Surgical Research Group at the Population Health Institute, or like we call it, PHRI. Dr. Devereaux is a Tier 1 CRC in Perioperative Medicine, president of the Society of Perioperative Research and Care. What is not in the bio, but I mean, you can see from his publications, you were lead and principal investigator in several international multi-center RCTs that have, clinical impact. I know you from the post trials, NeuroVision trial, that's how we came to know you. I know more recent hip attack trial, and you're part of many methodological papers on evidence synthesis and systematic reviews. Again, that's how I came, I saw your name several times. And it was, pleasure working with you. And I hope our grant will get funded one day and we'll be able to work together. And I think today's topic is, in this technology era, it's something really, really interesting. So I cannot wait to hear from you.
Good. Well, huge thanks for the very kind introduction. And that trial, your study is definitely going to get funded. It's important, and it's going to be a great study. So anyways, thank you for the opportunity to present here today. So I'm expected to put up my disclosures as part of our university policy. So I'm a member of a research group, which is a policy of not accepting honorariums or payments from industry for our own personal financial gain. We will, however, take as much money as we can humanly get from industry to undertake research endeavors. And based on study questions I've originated and grants I've written, I've received grants from many different companies. I'll be speaking a lot today about the issue of virtual care, remote automated monitoring technology, and the one company you should be aware of that we work with is CloudDX. They're a Mississauga-based company, and I'll show you some of their technology later on. So you should be aware of that potential conflict. So the goals of the presentation is that I first want to help people understand when and where surgical complications occur. I will then offer my perspective. I enjoy history, and I'll offer you my own historical perspective on what I think have been the major paradigm shifts that have improved overall surgical safety for all surgeries, not individual surgeries, and gain insights into potentially what might be the next paradigm change. And also, I'll tell you a little bit about our new perioperative care division and program here in Hamilton. I'll start off with a case. So this is a 83-year-old female who had a history of high blood pressure, and she had a 20-pack-year history of smoking. She had stopped smoking 30 years previously. She had no known history of coronary artery disease, cerebrovascular disease, or peripheral arterial disease. Her ejection fraction was 60%, so in a normal range. She had a rectal vaginal fistula, and she normally takes candesartan for hypertension, which is a angiotensin receptor blocker medication. She took her normal dose of 8 milligrams on the morning before her surgery. Her surgery was occurred on February 7th. It was a lower anterior resection, loop ileostomy, and a vaginal wall resection. So it's a big surgery. It occurred between 18:25 and 2200 at night, so it's a late day case. Intraoperatively, her systolic blood pressure was 80 for 10 minutes and 90 for 20 minutes. And I can tell you that we do a lot of research and collect a lot of data on intraoperative hemodynamics and postoperative hemodynamics, and that is relatively unremarkable hemodynamics. That would not be very alarming in terms of those parameters. The patient, for pain control, had an epidural put in for the surgery and has the epidural still in post-operatively. And when it comes out of the OR, also has an IV running at 125 cc's an hour. The patient arrives on the surgical floor on February 7th at 2300. And at that time, the vitals are measured and noted, and the heart rate is 91 and the BP is 110 on 55. The next time the vitals will be documented to be measured will be 5 hours later at 4 in the morning. At 4 in the morning, the heart rate is 84, but the blood pressure is now 78 on 40. So this is certainly a concerning blood pressure in this patient. The surgery resident is called, and the surgery resident is just going into the OR. They're just starting a case, and the surgery resident orders a 500 cc bolus of normal saline. At 6:30, the vitals will be next recorded to be documented, and the heart rate is 76, and the BP is now 70 on 38, so very concerning. The surgery resident is called. The surgery resident is still in the OR. They're still doing a case. The surgery resident orders CBC and some blood work and says they'll be up as soon as the case is done. The surgery resident arrives around 8 a.m. The heart rate is now 80. The BP is 75 on 36. The hemoglobin comes back at 94. And the surgery resident orders 1 unit of packed red blood cells, so a transfusion, and also orders an ECG. This shows you the preoperative ECG. And in general, this is a reasonably unremarkable ECG, minimal criteria for LVH, maybe Q-wave in V2, but not clear enough. Nothing very impressive on this baseline ECG, and it's a normal sinus rhythm. This is the ECG that they get back that morning. So this ECG is dramatically different than the first one I showed you. And so what you're seeing in this ECG is that we now have this QS pattern in lead V1, V2. We see substantial ST depression, this segment right here, in V3, V4, V5, V6. We see ST elevation in AVR over here. Also some ST depression out here in lead 2. So very concerning looking ECG. At 10:30, the patient's systolic blood pressure is 60 and a code is called. We end up seeing this patient, we admit them to CCU, patient gets inotropes and fluids. BP normalizes, troponin is elevated, which is a marker of heart injury, consistent with the patient having had myocardial injury for non-cardiac surgery. The next day, the patient gets chest discomfort for 20 minutes, goes to the cardiac cath lab, has a mid left anterior descending coronary artery, 85% obstruction, ends up getting an intervention and a stent, and the patient does okay. And, so what some people could say is, well, good, things worked out, everything went okay, but I would characterize this as a near miss. This was very close to the patient not surviving, and things could have went very, very easily. The patient may not have survived all this. And if you look back at the case, we have these huge periods of time where we don't know what's happening with the patient. The patient has had surgery, they're post-anesthetic, and they're getting an epidural, which can mask typical symptoms that a lot of time alert patients that something is wrong. And there's substantial periods of time where we don't know what's happening, and then we discover they're hypotensive. We also later see an ECG that's very dramatic, but it's almost for certain that that ECG had been already dramatic for a substantial period of time before we ever detected this. And this highlights the limitations of our current monitoring systems that exist routinely across Canada and around the world in the non-cardiac surgery setting. So I now want to switch to tell you a bit about just the magnitude of issue that confronts us when we think about surgery. So globally, there's over 230 million adults having major surgery every year. So there's a very large population of people, and this continues to grow. In Ontario alone, in the last decade, surgical volumes have increased 400%. If you look at 30-day mortality of patients who are age 45 or greater having non-cardiac surgery in a global context, this comes from the VISION study, which was a international prospective cohort study of 40,000 patients that we undertook that was a representative sample of people having surgery. 1.8% of those patients were dead in a 30-day period. In Western countries like Canada, it's 1.1%. But when you think about the number of deaths that are happening, it's a lot. In fact, research shows in the States that if mortality within 30 days of surgery was made its own category of death, it would be the third leading cause of death in the United States. Now, another interesting thing from the VISION study is that we demonstrated that almost no deaths occur in the OR. So of the patients who would die, only 0.7% of the deaths happen in the OR. Now, this is interesting because, you know, certainly in our culture, most people, when they think of surgery, they think of loved ones anxiously waiting in a you know, sort of the outside the OR for the surgeon to come tell them if their loved one survived. And the interesting thing is that even though the OR should be the highest risk period, it in fact is the safest period. It was not always that way, and I'm going to talk more about this in a moment. But in fact, the OR has become the safest period. And even though, you know, people come out and they feel reassured that the surgeon tells them that their loved one survived the surgery, the real risk to the patient is coming in the next number of days after their surgery. So if we look at the deaths, 70% of the deaths that will occur during the index hospitalization after surgery, and 29% of the deaths occur after patients are discharged home within that 30-day period. And obviously, no one is sent home to die, but a lot of times patients are sent home, complications have been missed, which I'll talk about in a moment, or complications happen, but we have a very suboptimal monitoring strategy for these patients in the hospital and unequivocally when they go home, which makes them vulnerable to have bad outcomes. And also, if you look at all comers age 75 or greater having non-cardiac surgery, 7% of these patients were readmitted to the hospital in a global context, and that is also consistent within Ontario. And this is a very common problem, which has huge implications because of the amount of surgery we're doing and how many beds that blocks, and obviously having unfortunate outcomes for patients. This is data from the VISION study where we were looking to see which postoperative complications were independently associated with 30-day mortality. And the way the table is set up is that the postoperative complication is in the first column, and it tells you the number of patients that had that complication out of 40,000 patients. And then the next column shows you the percentage of the patients that had that complication who died. And then the next one shows you the adjusted hazard ratio. And the final column shows you the triple fraction. And the triple fraction, I would advocate, is probably the most important statistic on this slide, because the triple fraction tells you if this complication is truly causal of death after the adjustment for preoperative and surgical variables and the other complications, this is the minimum proportion of deaths that in fact it is accounting for. And what you see when you look at this is that the three dominant things that lead to death in the first 30 days after surgery are bleeding, MINS, which is myocardial injury after non-cardiac surgery, and infection sepsis. Those are the dominant pathways through which patients die. And a lot of people tend to think that venous thromboembolism, so pulmonary embolism, is the most common cause of death after surgery. 40 years ago, it was a very prominent cause of death after surgery, but in today's world, in fact, is a very uncommon cause of death, accounting for only 0.3% of the deaths based on our models. Understanding the magnitude of death and complications that happen in the surgical setting, before I get into what I think is potentially going to be the next paradigm shift to improve this, I want to offer an historical perspective. And so I take this historical perspective from having read a number of books on the history of surgery and anesthesia and a number of articles on this. And I believe so far in the history of surgery, there's been two fundamental paradigm shifts that have dramatically improved the safety of all surgery. I want to be clear, there's been many advances within individual surgery. So as an example, when patients have an abdominal aortic aneurysm, when the world moved from doing open surgery to doing an endovascular approach, for that surgery, that was a big advance. But I'm talking at the level of what has improved all surgeries in terms of safety. And I think so far, historically, there's only been two major shifts or paradigm shifts. The first I put forward to you, and the two are actually interrelated, but the first I put forward to you was the sterile technique. So around the 1840s, the picture of this gentleman here is Joseph Lister, and he's a surgeon. He trained in England and he spent most of his career in Scotland. And this is before germ theory was established. And at that time when people did surgery, they noticed that a lot of patients would get these red, inflamed, pussy-looking wounds, and they would be high risk of actually dying. And Joseph Lister, as a surgeon, was obsessed with this issue. Now, a challenge that made this problem, that exacerbated the problem, is that also at that time in history, there was no anesthetics. So a challenge was, because there's no anesthetic, you can imagine, you're doing a major surgery. A common surgery, in fact, was amputation. So you can imagine if you walked into a room with no anesthetic and you're going to chop off someone's leg, how that's going to go. And you might guess, well, how do they do it? Well, how they did it, and what was the mark of a great surgeon at that time, was how fast you were. You had to be incredibly fast because you didn't have time to mess around, because the patients were going to go crazy with pain. And Joseph Lister, there's all kinds of accounts of this guy as, one of the fastest surgeons that have ever lived. And there's, in fact, one very comical account of one of the stories around Joseph Lister. There was once where, in fact, he did surgery and 3 people died as a result of the surgery. So one was, he did surgery, the patient got infected, the patient would die. Also, he was so fast that, in fact, what happened was, when he went to do an amputation, he sawed off his attendant's finger. They ended up getting sepsis. They ended up dying. And someone, seeing the guy lose his finger, fainted, fell down, hit his head, and he died also. So it was obviously a very different world than what surgery is today. But because there's no anesthetic that fast. Now, another implication of this was that what would happen is, commonly the surgeons would go to the anatomy lab just before doing a surgery and rehearse the surgery, and then they'd leave the anatomy lab. And at that time, germ theory doesn't exist. No one washed their hands, no one changed their clothes, and then they went in and they performed the surgery. And as you might guess, obviously this was frequently bringing a lot of bacteria. Now, Joseph Lister was obsessed with this entity they recognized as sepsis. They thought at the time it was mainly inflammation and sepsis, but and a buddy of his was Louis Pasteur, and through a bunch of things, he started to wonder if, in fact, they were bringing something from the anatomy lab into the OR. And then he was one of the people at the forefront of thinking, maybe, in fact, they should wash their hands, maybe they should change their clothes, and then also maybe we should clean wounds and try to keep this sterile. That movement ended up having an enormous impact on improving surgical safety. And this all, preceded germ theory at this time. And then the next major advance I would put forward to you, which is a crucial one for insights of where I'm going to go, is actually anesthesiology. So it was actually in the late 1840s that the first anesthetics come along, in the sense of having a huge revolution in terms of our ability to practice surgery. And if you just look at progress in the last 100 years, so 100 years ago, decent research showed that about 1 in 1,500 patients died from an anesthetic complication. And the reality was, 100 years ago, surgery only happened on young, relatively healthy people with very little comorbidity. And in today's world, 1 in 200,000 people die of an anesthetic complication. And despite the fact that we're mainly doing surgery on much older patients with a lot of comorbidity. And you might ask, well, how is that possible? Because it's going in the complete wrong direction of what you would have predicted. And like many things, I think it's probably multifactorial. But I do believe that there's 2 really crucial things that happened. Anesthetists were now having a physician who was not the surgeon, who was being designated to be responsible and present and available to manage the patient's physiological stability. And they're very smart physicians, and they're standing over patients, and they're observing patients. And like anything in life, if you focus on things enough, you will then start to figure out the problems, and you'll experiment and get better at doing this. Secondly, which was also a crucial advance, is they brought monitoring technology into ORs. Because a challenge when you're doing surgery, if you're doing general anesthetic, the patient can't communicate or tell you if something is wrong. And even if you're using regional anesthesia, a lot of times it can be blocking sensations for a patient to recognize if something is wrong. So anesthetists brought all this monitoring technology into the ORs, and in many ways, ORs are now safer than the ICU, because the big value that you have beyond an ICU, even though the monitoring now is very similar, is that the anesthetist never leaves your side, whereas that is not the case in an intensive care unit setting. So what is the reality of postoperative care in Canada and around the world? So care providers in hospital, patients usually care by their surgeon, and the reality is surgeons are doing what they love doing. They're often doing surgery, and patients don't wait to get sick, waiting till the surgeon has done their OR. If patients get sick now, they get sick now, whenever that is. And after discharge, patients typically will see their physician, between 2 and 8 weeks. after their surgery, which obviously leaves a lot of time where, in fact, many things can go wrong. And when we look at monitoring, in most hospitals in Canada, when people go back to a surgical floor, they typically have their vitals being checked every 4 to 8 hours. And again, if patients are getting pain medication that commonly masks typical symptoms that might identify patients getting into trouble and they're post-anesthetic, that leaves patients very vulnerable to having significant problems that will be delayed being detected, which I'll show you more about in a moment. And when people leave the hospital, essentially there is no monitoring outside of some very unusual situations, but pretty much globally, most people are not monitored at all when they leave the hospital. So I'll show you some research that offers some insights into how much this suboptimal monitoring may be causing maybe a problem. So this is a study that we did where we took 833 patients who had a major non-cardiac surgery and went back to the surgical floor. We had nurses measure vitals as they normally did, and we were using a number of technologies that were blindly capturing data in the background. And one of the things was blindly capturing in the background was continuous oxygen saturation by using an O2 sat. Nurses were told to measure vitals as they normally did. Nurses told us that 5% of the patients became hypoxic and had an oxygen saturation less than 90% amongst all of the participants. When we look at our technology that was blindly capturing data, looking at the 95% of patients that the nurses said were not hypoxic, what we identified was that 38% of the patients who the nurses said were not hypoxic had at least one episode where their oxygen saturation was less than 90% and persisted for at least 1 hour in duration. And 10% of patients had at least one episode where their oxygen saturation was less than 85% that persisted for at least 1 hour. And there's a lot of research depending on your underlying anatomy, but even hypoxic episodes for 15 or 20 minutes can in fact lead to cardiac ischemia and other major organ ischemia, which can get patients into trouble. So a lot of patients have significant hypoxia on our surgical floors that is not detected with our current monitoring strategies. If we look at hypotension, this is a study from Dan Sesler, who is a close collaborator of ours from the Cleveland Clinic. And Dan and his group were using the THETA continuous non-invasive blood pressure cuff on 300 patients who had had intra-abdominal surgery. And they used this continuous blood pressure cuff on the floor that blindly captured data, and they told the nurses just to collect data as they did. And it's a similar observation that there was lots of patients who had significant hypotension on the surgical floor that were not identified, or there was substantial delays in the identification. And the reality is the Cleveland Clinic is actually very impressive, and people do get their vitals, every 4 hours, whereas that is not the reality in our research in most Canadian centers. So this is probably an optimistic perspective of the delays and how often hypotension is being missed in reality in surgical floors. In the vision study, that we also demonstrated that 93% of the patients that had myocardial injury after non-cardiac surgery occurred without ischemic symptoms that likely would have gone unrecognized unless we've been measuring troponins. So we were measuring troponins in all these patients, which is a marker of heart injury that allowed us to then evaluate these patients to see whether or not they were having a heart injury. But if we hadn't been measuring that, we would have missed 95% of the events or 93% of the events because a surgeon never would have been triggered to measure the test because the patient wasn't complaining of any symptoms. And the reason we think this happens is, again, most patients are getting, often narcotics during the first 24 to 36 hours after their surgery when the majority of these events happen, and narcotics are very good at masking typical cardiac ischemic symptoms. These elevated postoperative troponins without ischemic symptoms are independently associated with an increase in 30-day mortality with an adjusted hazard ratio of over 3-fold. Again, just highlighting that just because there's not symptoms, it does not mean the event is benign. This is data from a trial that we did called MANAGE, where we randomized patients who had these troponin elevations after surgery. And what I just want to make the point to you is that these events that happen, they're likely modifiable events. In this trial, we randomized patients who had MINS to either get dabigatran, which is a blood thinner, or placebo. And there's a few things I'll draw your attention to on this slide. So the first thing is that dabigatran reduced the risk of major vascular events in the next 24 months with a hazard ratio of 0.72. So it's about a 28% reduction in major vascular events. That's vascular death, non-fatal MI, non-fatal stroke, and not major peripheral arterial thrombosis or venous thromboembolism. And what you see is that in the first 2 weeks after patients have MINS, there's an initial spike in events. So 5% of people in the placebo group will have a recurrent major vascular event in the first 2 weeks after MINS. We then saw an instant divergence of the two curves favoring dabigatran. They continue to divide until about a year, then they remain parallel. And then even at 2 years, it's not obvious that we've seen a plateau in the events. And the event rates are extremely high compared to most things in cardiovascular disease that we treat, where in this setting, over 15% of patients in the control group have had a recurrent major vascular event. Another aspect, and this is where Lucine and Eric and I have been having discussions, is on the issue of what about neurocognitive issues that happen in the surgical setting, and specifically stroke. So Neurovision was a study that we undertook where we took just over 1,100 patients who were age 65 or greater, had undergone an elective major non-cardiac surgery, and we did brain MRIs in these patients 2 to 9 days after surgery. We had 12 centers in 9 countries that participated. 7% of the patients had a new covert, that is a silent stroke, on their brain MRI. And because we're using diffusion wave imaging, we know that these are new strokes that occurred in the last 10 days. And these new covert strokes, which are not uncommon in patients undergoing non-cardiac surgery who are older, increase the risk of perioperative delirium with over a 2-fold increase in risk. And importantly, which was our primary endpoint, increase the 1-year risk of cognitive decline. 42% of patients who had a covert stroke had cognitive decline in the year after surgery. And also, alarmingly, 29% of people who did not have a perioperative covert stroke had cognitive decline 1 year after surgery. And so it ended up being a 2-fold independent risk of having cognitive decline 1 year after surgery if you have a perioperative covert stroke. And also the patients who had a perioperative covert stroke, the 1-year risk of going on to a recurrent overt stroke or TIA was a 4-fold increase. Again, identifying these events that happen perioperatively, which if we hadn't been looking for these by not doing MRIs, actually have real consequences to our patients and loved ones. This identifies the need to continue intraoperative research, which has been the dominant focus of research. However, we need to dramatically increase research outside of the operating room, and we have to have a willingness to change structural issues and also be disruptive if we're really going to dramatically change and improve safety the way it has been improved in the OR in the post-operative setting. I think we need to learn from the story of anesthesiology. I think that the potential for a third paradigm shift to improve surgical outcomes consists of 2 components. One is new perioperative care services that are dedicated and available to co-manage patients with surgeons after surgery on surgical floor, and also to do transitional care to patients into the home setting. And also that we need to do away with our antiquated system of having nurses check vitals every 4 to 8 hours and use advanced technologies that can remotely and automatically measure vitals for us and give us information on this in our patients. I'll now tell you about 2 trials that we're doing. One we've just finished and one it's gotten interrupted for COVID, but hopefully will be finished soon too. The first one is SmartView. Mike McGillian, who's in our group, is the PI of SmartView. Mike is outstanding. We stole him from Toronto, so he was very good. We're very, very fortunate to have Mike in our group. So SmartView is a randomized controlled trial of 800 patients. We've randomized 600 patients at this point, but these are patients who are admitted to a surgical floor after cardiac or vascular surgery. And the patients are randomized to either standard care, so nurses measure vitals and manage the patients as they normally do, or they get the Philips remote automated monitoring technology with alerts and monitoring into the home setting. And our primary endpoint, we're looking at what happens in the hospital, but also trying to prevent hospital readmissions and ER visits. In hospital, patients in the intervention group get this Philips technology where you have basically a monitor that's measuring respiratory rate, oxygen saturation, their heart rate. It's an automatic cuff. That technology is not great because patients get irritated with automatic cuffs. And then this gets measured in the background, like the heart rate and the oxygen saturation and rest rate is continuous, and we set the blood pressure to be measured every 2 hours during the day, and then I think it's every 4 hours at night. And if patients, we then have built in the background sort of a risk score, which will escalate care based upon how those parameters are looking to make sure that it goes to a nurse or a resident or a physician or our RACE team. When patients go home, they go home with this technology. So they're given a tablet, which gives them 24 hours a day virtual access to a perioperative care nurse and physician, a thermometer, a blood pressure cuff that also gives us their heart rate. And also we can measure the respiratory rate and a scale to measure their body weight. And they use this technology for 30 days post-discharge after their surgery. So again, that trial is hopefully will finish in the next sort of 4 to 5 months. It just got derailed because of COVID. But I'll tell you now about the PVC RAM trial, which we conducted during COVID, and we just recently finished. So this is looking at post-discharge after surgery, virtual care, and remote automated monitoring technology. And in this trial, early in the COVID pandemic, hospitals canceled elective surgeries. However, semi-urgent, that is cancer surgeries, or urgent like hip fractures, or emergency surgeries like a ruptured abdominal aortic aneurysm, those surgeries had to continue. And patients who were discharged after non-elective surgeries before COVID, 20 to 25% of those patients would come back to an acute hospital care within 30 days. And obviously that then puts a stress on the system because that then starts blocking up beds. And obviously, as hospitals now struggle with COVID-19, in many cases have resumed elective surgeries, there's a need to reduce the surgical patients' post-discharge use of acute hospital care to ensure that we can deal with the wait list that now is this huge backlog of elective cases waiting to be done. But if a lot of the patients who have surgery get discharged and get readmitted to the hospital, they're going to block beds and minimize our ability to have that happen. So the rationale for virtual care and RAM post-discharge is that after hospital discharge, patients typically see their surgeons 2 to 8 weeks after surgery, and these timelines can result in delays in recognizing and managing complications, which can lead to rehospitalization and poor outcomes. And early identification and management of complications has the potential to reduce acute hospital care. So PVC RAM1 was a randomized control trial. We randomized 905 patients to virtual care and RAM for 30 days. And there was 451 in that group, or standard care, 454 patients. We included patients who were age 40 or greater who were being discharged after non-elective surgery. We had 9 centers in Ontario and Alberta who participated. The intervention was we gave patients a tablet computer and RAM technology. This was from CloudDX, which again is a company here in Canada. It's based out of Mississauga. And the intervention allowed, with the RAM technology, for us to get blood pressures, heart rates, respiratory rates, oxygen saturation, temperature, and weight. Patients also completed the recovery survey daily for 30 days. We also got a wound photo daily for 30 days. And the virtual care nurses interacted with the patients daily from day 1 to 15, and every other day from days 16 to 30, unless the vitals on the off days met our alert systems, and then the nurses would call those patients even if they weren't scheduled for visits. Patients always had the ability to contact us 24 hours a day with the push of a button, and they would have access to healthcare providers. This shows you the CloudDX technology that we use in PVC RAM. So you have a big tablet computer that gives the patients easy access to their healthcare providers, and the other technology for the blood pressure, heart rate, thermometer, and oxygen saturation and scale is Bluetooth enabled and very friendly to use and easy to set up. So as I said, the trial's completed. The main results are now under review, and hopefully will be published soon. And we remain very enthusiastic about the potential for virtual care and RAM to really change the ability to do things in the outcome. But I will offer this point that I will share with you, is that I think the thing we have to recognize is that if we think that giving people just monitoring technology will change outcome in itself, I think that is a low likelihood. If you have to have a system that can respond to the problems and abnormalities in a very timely way. And if you have that, you can then have huge effects in terms of changing actual outcomes for patients. This is just to mention where we're going. And this, we're getting ready to start the Vision 2 study, which will be a 20,000 patient prospective cohort study that we'll undertake around the world. And hopefully, with Lucine and Eric, we'll definitely be embedding NeuroVision 2 in that, but hopefully also their study can hopefully be part of that too, looking at PFOs and patient having strokes in this setting. But in this setting, we're going to be using the tricorder device, which CloudDX won the X Prize for 2 years ago for the boldest health invention. It was a global competition. And this device that this woman is wearing around her neck allows us to get continuous non-invasive heart rate, heart rhythm, and continuous non-invasive blood pressure, temperature, oxygen saturation, respiratory rate, 5-lead ECG, movement, body position, fall detection, sleep analysis, and also steps. And it is, I think, really when we move to this next generation of technology, where we can get continuous data, that we have the potential to really revolutionize things in a big way. Now, as you would guess, this obviously leads to crazy amounts of data and obviously the need for AI to be involved in terms of helping to deal and manage with this data and help to also identify the patterns that can tell us this pattern is highly predictive that this patient's going to be diagnosed with sepsis 12 or 24 hours from now, or a bleed 6 hours from now, or myocardial infarction, 8 hours from now, whatever it is. We're very optimistic that that's going to be able to make a big advance with our patients. I'll then briefly mention that a year and a half ago at McMaster, we created a new division of perioperative care. This is a multidisciplinary division that includes anesthesia, medicine, surgery, rehab, and surgery. It's an academic division and also clinical services. The clinical services basically co-manage with surgeons during the hospitalization and then also undertake transitional care in the home setting. It's a phase-in approach where we have these models up and going at the Hamilton General and the Jarovinsky Hospital, and hopefully we'll be expanding to St. Joe's in the near future. And again, I just want to emphasize the point that technology allows us to get into the game and have a much greater chance to change outcome. But if you don't have the structural system ready to respond to abnormalities and change care based on it, we won't affect outcome. And that's why the human part of these systems is equally crucial. So my takeaway messages are that patients undergo surgery for very important reasons. We should never lose sight of that. There's a need to improve surgical outcomes to the point where anyone can have surgery and not have to worry about this. To do that, we need to implement what we know, but we also need to avoid missed opportunities, and we need to conduct a lot more research. I believe we should learn from the history of anesthesiology, and we believe that virtual care, remote automated monitoring technology, along with clinical services that are dedicated and focused on this, have huge potential and may, in fact, represent another paradigm shift to really improve the safety of surgery overall. So with that, I'm going to stop, and I'd be happy to take any comments, questions, rebuttals, anything like that.
Thank you, PJ. So we have questions that have been already typed, and then we have a hand. So do you want, which one you want? We have a question from Dr. Alandetsky and a few questions from Dr. Ira Fleming. So
I should mention that, as a cardiologist, it's kind of unusual to be focused on perioperative medicine, but I did an elective when I was a medical student with Alan Detsky, and I've often told Alan many times it was that elective that made me realize there was a huge field waiting to be discovered and sorted out, and I'm very grateful to Alan for having exposed me to this area. And he's obviously one of the people who was at the forefront of when perioperative medicine was really just being born in terms of a focus.
I guess I will start with the question from Dr. Alandetsky.
How do I talk?
We can hear you now. Yeah.
Okay. Wait a minute. I'm going to turn on. Is there a camera? I can't see where to turn on the camera, or maybe you can't do it.
I can't. I don't know. We have technical stuff. Silent.
There's no.
I don't think I'll be able to do it for you.
Oh, okay. Never mind. I can just talk.
Yeah.
PJ, can you hear me?
Yeah, I can hear you, Alan. Nice to hear
Yeah.
from you.
Nice to see you. Wish you could see me.
Yeah.
I think I look as different as to you as you do to me. No, but I have seen you in the interim, and I do remember very well. I mean, the reason I'm here is I remember very well that PJ was a elective student for McMaster and did the perioperative medical consult service with me. I even remember some of the cases, which were lots of fun. So you had you had a big impact on my memory as well. So this is all you've done fabulous work in this, like over the years, and I was thinking like how much more important the stuff you've done is, or how much more complicated the stuff you have done is than what I did in this area many years ago. So I have some comments. That was the nice part of my comments. Now it's the attack, which I think you knew was coming. So you obviously understand the sandwich of the meat of the sandwich that which is that if all you're doing is detecting abnormalities without actually being able to intervene in them, then this isn't going to actually help patients. So, and you're pretty clear on that. So some of the insights that and some of the things that I worry about are based on results of other people. Irfan Dalla did a trial of something called the virtual ward for internal medicine patients.
I'm very aware of that one.
And that didn't help. The patients actually liked it because there was more opportunity for them to talk to people, but it actually didn't help them. And then Harriet van Spal also did an in-home monitoring thing for heart failure patients, randomized trial, and it also didn't help. So one of the things I worry about when I see this is twofold. Number one is the signal to noise ratio. And so you're going to be, the more you monitor, the more things you find, the more opportunity you have for somebody to do an intervention. And then you have a risk benefit ratio that comes from over investigating people and responding to noise versus under investigating people without responding to signal. And when I listen to all of the monitors that are in the hospital that beep and constantly go off, the vast majority of the signals that they're sending are noise and not real signal. So I kind of worry about how you are going to be able to figure out how to filter out the noise from the signal. And the second part of the question is, if the respondent to the signal doesn't have the right scope of practice, and this is what happened, I think, in Irfan's trial, was that people saw what was wrong, but they didn't have actually, I'm sorry, there was a trial that was done at McMaster that was in the CMHA, and I happened to write an editorial for it, and that's how I remember it, in which there were nurses who could respond to signals, but their scope of practice wasn't wide enough for them to be able to deal with them. So the patients just ended up back in the emergency ward. So these are you're very hopeful that this is going to reduce readmission rates and burden on the healthcare system. I actually think it's probably by generating more signal, it's going to generate more work for the healthcare system. I'm not saying that it's not going to be worth it. So those are the two aspects: signal to noise ratio and scope of practice of the respondent. I'm sure you've thought of both of these things. Can you tell me what your thoughts are about them?
Yeah, so I mean, I wish that we could show you the results of PBC-RAM 1 at this time, and the points you're raising are extremely important points, Alan, and I think that's where, like, I think when you overall look at the research that's happened with virtual care and remote monitoring technology, number one, it's inconsistent and it's underwhelming. But I do think, at least in PBC-RAM 1, one thing became very clear to me, the point you're making. If you just have people that are identifying, hey, there looks like there's a problem, but you have people who are not able to address the problem because of the scope of care, or not engaged and willing to, get involved with the problem and address it and change care, you won't change outcomes. But if you do have it and you have the right structure, it becomes possible, I believe, in this setting. But there's a lot more work to do that. And you're right that obviously the tension becomes that, do you get alarm fatigue versus, you wait too long and it's too late and the patient's going to be really sick and they're going to have to come into the hospital. And that's why I also believe, Alan, is that it's going to be moving to these much more advanced monitors where we can get into continuous data with much higher fidelity with a lot of biophysical parameters, that I think we get to a closer place where we'll have much better detection of what are true signals of a problem is serious and it's brewing, before it's obvious clinically versus just noise. But that will be the tension, and it's why it's going to need research. But I think models that just think you will give the technology, and naturally, because a problem will be identified, it'll be easily addressed and things are going to go well. I think I'm convinced from our experience so far, it just does not work. But if you have the right group who is engaged and has the scope of practice, as you're pointing out, that can address it and are available in a timely way to address it, I do think it can happen. You also raise a great point that it's not free. And in fact, it also does require work. It'll be interesting to see ultimately where all the economic analysis come out once we get models that truly, are efficient and work. I think it's clear to me that we have some models that can work, but I also think we still have to make them more efficient. I think part of how they'll become more efficient is getting better technology that gives you continuous monitoring. And then it's just doing a lot more experimentation of how to do this right. But, I'd also say that in terms of the monitoring, it's like the reality is no one's ever done research to say, why are we measuring vitals in the hospital and our patients on the medical wards, in the CCUs, whatever. But I think all of us as healthcare providers would think that that sounds a bit, obvious, because we see patients at times that are being identified that was unknown to us, that are in serious trouble. And so I think it's the technology just has to be sorted out in a way that allows the providers that are enabled and have the scope of practice to actually address it. And you have to find ways that it's efficient and economically viable. I think that's doable, but you raise a great point, Alan. I may be overly optimistic, but I'm certainly encouraged by our early trials in this area. And I'd also say that Irfan's trial, his trial was in the direction of benefit. I would argue that it probably was underpowered. But you might say that even if it was an effect, you would want a bigger effect, but it was in the direction of benefit. Harriet's trial was a stepwise design. I personally have substantial reservations about that design in terms of how at times you may miss signals. But a lot more work needs to be done to sort this out, and we will have to be taking into account the economics of it, because it's not free. At the same time, I can say this to you. I'll share two things from the results that I think help to put a context. One of the things I was nervous about when we were doing PBC RAM 1 is that our estimation of ER visits and rehospitalization was based on pre-COVID world. And obviously in the COVID world, people were much more, hesitant to come back to hospitals. But I can tell you that 9 centers in Canada, if you're looking at non-elective surgeries, 27% of patients came back to the emerge, of which half were readmitted to the hospital in a 30-day period. That's a very high number, and that costs serious money. The other thing that we did identify, Alan, is that when patients went home, we identified that 30% of patients had drug errors, and on average, they had 2 drug errors. And I just put forward that those are even just some small things that suggest that there is a substantial magnitude of problem on the side of what is wrong, which also gives the potential to improve that.
Thanks. Nice to see you.
Nice to see you, Alan. Or nice to hear you.
We have 4 questions in the question and answer window. I don't know, do you see them? And we have some comments in the chat.
No.
Or I can read if you don't
Yeah, if you don't mind, or let me.
Yeah. Yeah. Maybe just see. Under Q&A, there should be. I don't know if you see.
Well, I like the comments about anesthesia and surgery working together. So
yeah, that's the chat.
I'm not gonna venture into that. But I mean, obviously, both people are essential. Obviously, the surgeon is essential because they're doing the surgery. But there is no doubt when you look at the data, what's happened the last 100 years, intraoperative mortality has plummeted, and the monitoring and having anesthetists there to respond to the physiological abnormalities has had a big impact. There's no doubt about that. The home monitor does not appear to measure cognition. Yeah, or Biz. So that is true. Ours doesn't. We've done some work with NIRS, and there's the potential that something like NIRS might be possible even to go into the home setting. I do think that, you know, a lot of my focus has been on the perioperative cardiac events, which they matter, but at the same time, I would fully acknowledge that the cognitive issues are way more important. You know, in neurovision, seeing that 7% of people have covert strokes and that they are, you know, associated with substantial risks of delirium and then cognitive decline 1 year after surgery should give us all pause. And certainly, you know, there's a need for work to sort out how we're going to prevent that and better manage it. And I think having ways to also just better measure patients, even going to the home setting in terms of whether or not they're having cognitive issues is very worthwhile exploring. So hopefully, again, we will get technology that'll be able to help with regards to that. And so 2 questions about inclusivity of the RAM interventions. Some remote monitoring technologies are channeled by patients' characteristics such as skin color. Have you encountered similar challenges in your studies? I've read about this issue. We've not with the technology that we're using, but certainly I know for certain things that can become a problem with some patients who are darker skin with certain types of monitors, but the stuff we're using at the moment, not been an issue so far. And how do you address low health literacy? Yeah, so one thing I'll share with you, as I mentioned, Mike McGillian, we're very fortunate that, you know, he joined our group. And when we were just, you know, starting to venture into this, I remember like, you know, Mike saying, yeah, I think we could use this technology with patients. And, you know, I'm thinking of all of it's mostly elderly patients that are having these major surgeries. And I'm thinking, are they really going to go home and use this technology? And what's going to happen? And I must say that I was, you know, really surprised when we started doing SmartView, how the patients did incredibly well with it. And the thing that was remarkable to me is that we had the experience where some patients didn't want to give it back. And it was really because they having access to healthcare providers, it's a point that Alan raised earlier from IRFAN study, patients love it. I mean, like who doesn't want to have access to a healthcare provider very quickly, but you know, they were able to use the stuff and it's got to be made, you know, simple, user-friendly. The stuff I showed you at the end, like the tricorder device, the patients just put it on, it does everything for them. They don't have to do anything. And I think that's ultimately where the technologies are moving, and that's what's going to make the technologies the most successful. So I think hopefully we make it so it's so simple that anyone's going to be able to do well with it. So I have some reservations about the facilities and disengagement of surgeons from the clinical recoveries. Surgeries could, in principle, become possible for anyone, but the outcomes need to be accounted. The reselection of the post-operative care remains largely on the shoulders of surgeons. So I agree that I think in the broadest context, you know, of surgery that's happening in Canada, overwhelmingly the surgeons are the ones in most settings that are responsible for the overwhelming care of those patients post-operatively. One could also imagine that a surgeon could try to do anesthesia and also do the surgery. I would just argue to you that even though surgeons need to absolutely be a crucial part of post-operative care, having physicians who are focused and develop specialty in perioperative care, who are available and not busy in ORs, has value. And also the reality is, you know, just with the time requirements with the transition to home, I think it's going to require other healthcare providers to also be playing a role in that. But I want to be clear, like, I hope nothing was misconstrued in what I said earlier. In our model, it's a shared care model. The surgeons and the perioperative care physicians are managing the patients together. It's not looking to remove the surgeons from the equation. But I mean, I guess the point I would say to you right now is that, you know, although it seems almost inconceivable, but, you know, 170 years ago, anesthetists don't exist. I don't think any of us would credibly consider having major surgery without an anesthetist today. And I do think in the future, we have the potential where perioperative care physicians, along with surgeons, and also nurses, post-operatively and transitioning to home could also become a crucial part of that care in a way that you wouldn't think about having major surgery without having that background support. Again, a lot of research needs to be done to prove that theory, but I do highlight when you look at the data, there's a lot of, abnormalities happening, and there's a lot of missed, physiological problems, and there's a lot of complications that happen. And I think unless you put people and technology onto it, it's not likely going to cure itself. And the reality is, we're just going to keep doing surgery on older and older patients with more comorbidity, which then lends itself to worse outcomes if we don't change the structure of the system.
Almost at a time. Very interesting. There are 4 questions, so I'm going just to pick one of them. That's because you, I think, answered some of them as you were talking. The question is, perioperative care has made a big effect on chronic pain associated with a significant fraction of surgeries. A big part of the success resulted from engaging patients and building a recovery mindset. What do you see as the balance between surveillance and engaging partnership? And the question comes from Peter. I don't see the last name, but the question is what you see as the balance between surveillance and engaging partnership.
Yeah, so I believe that in post-operative care, surveillance ends up being very important because we make patients vulnerable by doing a positive thing, that we want to control their pain, but we need to recognize that by using a lot of the analgesic medication we use, that sometimes that masks symptoms in patients that would normally identify to us that, hey, there's a problem going on here. So I think, just use as an example, measuring troponins after surgery, the vast majority of patients that have a prognostically important myocardial injury would never be detected if you don't measure troponins after surgery in higher risk patients. And as I was showing you with, looking at just significant hypoxia, if you don't have a system where you can, monitor hypoxia after surgery, you're going to miss the vast majority of it if you're just doing spot monitoring. So I think, surveillance is important, but you need, partnerships. And again, the monitors themselves don't solve the problem. They just get you in the game. If you don't have worked out a pathway of who and how you're going to respond to the problem, you won't change things. And that, I think, is where a lot of the research that has been disappointing with virtual care and RAM technology has happened. And certainly we've had our own experience, with that. And as I said, we have a lot more to share with that coming up. But I think, you need both sides of it, and you need to engage, industry from technology. We need to engage the payers, the government in terms of supporting the systems. We need to engage the public and the surgeons and everyone to actually make this type of structural change happen.
I think we are at the time, exactly 2:01. If it were like live session, we wouldn't let you go. Yeah. You'll be staying there in the corridor, just talking to us still. I don't see any more questions, but I see comments, people thanking you for this interesting and amazing talk. And I hope you will consider coming back in, maybe a year, and then, yeah. And usually before we start, we also go around, each of us, says who, it's nice to know who is your audience. Next time, hopefully we'll be in person.
Yeah. Well, again, thanks. Really appreciate the opportunity to speak. And it's been a pleasure to be interacting with you and Eric, and always nice to hear from Alan, who I owe a lot to, and wishing everyone good health as we hopefully navigate the last phase of COVID. Hopefully that comes soon.
Thank you so much.
Okay, bye-bye.
Yeah.